ये वाला थोड़ा लेट है एसपी मीटिंग कंपेयर टू अदर्स। वो जनरली इतना लेट नहीं होता, वो सितंबर वगैरह में। नवंबर तक तो बहुत, इट इज टू कोल्ड। Okay, so good afternoon, everybody. And today we are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around that 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think, what could have gone wrong and how could we have improved in that regards? So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country, but that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with a YouTube program which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now we have 14 fellows who have joined. So this is something, but then again, the reach is limited. To take it forward, we started with our Medi classes, which was our online portal, which takes it beyond the routine classroom to beyond, so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to take the implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the Medi Classes Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones which started off were approach pathways. Now, how these approach pathways were working were like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter. hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So that all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was an Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there. And you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the decay management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us in that perspective. So we'll talk about 6 gross major part of the disorders which are there, including growth, glucose, puberty, thyroid, sodium, and calcium, one by one. So growth, we know that this is a common scenario. So we have a child, 12-year-old girl, height is 132 centimeters, weight is 20 kgs. It's a common problem. Around 2.5% of all children are short. Most are physiological. 10% have a pathology. So the answer that we have to do as a pediatrician is to decide which does not require test and which requires test in that regards. So the most important, of course, we talked about is physiological, which is constitutional delay of puberty and growth of familial cause. And within pathological, we have got the primary problems in the growth plate, SGA, Turner, skeletal dysplasia, or secondary problem in the form of nutrition or endocrine. So the three questions to answer is it short stature? If it is short stature, is it physiological or pathological? And finally, primary or secondary. So to answer the first question, we tried to use pathological prevalence as a marker of what should be the criteria for short stature. So what we found is that as the height standard deviation score goes down from -2 to -3, the chances of pathology increase from 2.5% to 42% to 80.5%. So anybody who is less than -3 standard deviation has a red flag sign, needs immediate evaluation. And what we want to do through our app is to move away from percentiles and go more in favor of standard deviation score. Because when you talk about percentile, which is a good number figure, you're looking at a chart, but if somebody says less than first centile, it doesn't make any sense. When you say -6 SDS versus -3 SDS, you know there is a big difference in that perspective. So less than -3 standard deviation score is clearly a sign of worry. -2 to -3, you can follow up and look on that. Three things to look at in a child with short stature to identify physiology versus pathology are growth chart, puberty, and bone age. And when we talk about growth chart, we look at three major things. What is the absolute status? How is the child compared to the population in terms of percentile and SDS? How is the child coping as compared to parents in terms of target height and target height SDS? And finally, what is the nutritional effect in terms of whether the weight is more affected or the height is more affected? Continuing with the theme that I've been talking about in terms of standard deviation score, our algorithms take into only SDS in consideration. So we take height SDS to decide whether the child is short or not. Less than -3 usually means pathological. More than -2 is normal. -2 to -3 is considered as intermediate. For the parental height, we use corrected height standard deviation score. So if you have a child whose corrected height standard deviation score is more than -1.5, this is a familial. So he is not short for the family. For nutritional, we use BMI standard deviation score. And if BMI standard deviation score is more than -1, this is endocrine, less than -1 is nutritional. So you will get a large number of outputs when you look at the growth interpreter. You will get information about height SDS, weight SDS, BMI SDS, target height, corrected height. And this is all the algorithms have been already loaded, and it will automatically tell you what is the pattern of growth failure. And our newer tools are going beyond that also to suggest the likely workup also from that perspective. Now, pubertal assessment is absolutely important. And we know that breast stage 2 is the most important aspect as far as girls' development is concerned. So we need to identify breast stage 2, which in the modern era should be through palpation. Conventional Tanner staging is via inspection, but now because of obesity, a lot of lipomastia is happening. So we want to do a palpation to confirm that there is a true breast tissue there or not. From there, we expect 20 centimeter growth. Then we have secondary mount, which is stage 4. You get 10 centimeters height gain there. And from menarche, the height gain is only 5 to 8 centimeters. So if you have a girl, which I often say has a height of 135 centimeters, at stage 2, she will land up 155. If she is stage 4, she will land up 145. If she is menarchal, it will be like 140 centimeters. So you need to really look at puberty when you decide whether you want to do some intervention or not. Now, often there is problem in terms of pubertal assessment, particularly in boys where you need to really have a orchidometer to identify. So testicular volume of 4 ml indicates an increase in testicular size, and more than 10 ml will suggest that you need, there is a time when the growth spurt has happened. What we have tried to do is to develop a tool with which you can easily interpret the puberty. You can compare the pubic hair and the breast development to get an accurate assessment. And this is particularly relevant in scenarios where the patient is not easy to do it because of privacy issues. So you can give it to the mother or the daughter or the child who can be able to self-rate her in that regards. And this is something which we have developed. The major problem which was there in terms of growth assessment and particularly validated growth assessment was the bone age assessment. And the problem there was that people are not really trained and the radiologists are not really that much wanting to spend that much time in terms of bone age assessment. So for bone age assessment, we need the left hand or the non-dominant hand, stretched fingers, and assess the maturation and the fusion of epiphysis. The single most important thing to look at is the difference between the epiphysis and the metaphysis of the phalanges. If somebody asks me which is the one side you want to look at, that will be middle finger, middle phalanges, and around 95% of bone age can be predicted by that. But what we try to do is that conventional methods like Tanner Whitehouse talk about 20 ones, while GP Atlas is comparing the whole thing. So we try to see if we can minimize the number of sites to reduce the amount of exposure in that regards. So GP Atlas is matching one to the other. Very common, most commonly used, particularly in North America, is GP Atlas. The problem is not all bones grow together. So if carpal is, suppose, let's say, more mature and phalanges are less mature, then which one to use becomes a problem. That problem was addressed via the Tanner Whitehouse, in which each segment, a different segment of the bone, was given a particular rating. So this was something which was quite helpful. And then finally, we have the automated bone expert, which is available. These are limited by the cost of them as well as the time which takes in that perspective. So we decided to develop a bone age application and validated this using 5 sites, which reduces the time of this test and gives us early results. So this is how you do it. You just have to compare 5 different sites, and then you have got the middle finger, middle phalanx, middle finger, proximal phalanx, thumb, radius, and ulna. And this takes approximately 2 minutes even for a non-expert, with a good validation compared to the standard Tanner Whitehouse method. This has been used a lot, and we've got a lot of publications coming out from that regards. So finally, when you have assessed the puberty, the growth, and the bone age, there are 3 questions to answer. Is the child short? If not short for the population, no workup. Then short for the family or not? If not short for the family, target height SDS. Its corrected height SDS is within 1.5 or target height, nothing to worry. Then finally, short for bone age. In that perspective, this will be CDGP or other perspective. And less than -2, you do a systemic disorder screening. And otherwise, you do a growth hormone stimulation test only if they are clinical parameters. So this I'm not going to detail exactly, but this is what is imprinted already in the growth interpreter. And the algorithm will then decide about what way to go forward in terms of evaluation and assessment and management from that regards. So this is the tool which we published in 2021. And we found a significant over 98% concordance of mobile application with the clinical diagnosis. So it was a way, you just have to enter a few details and you will get what is the likely diagnosis, evaluation. Whatever I talked for the last 20 minutes or so, you will get it on a click of the button in that regards. I'll now invite Dr. Vibha to talk about our newer intervention that we are doing in the form of bone age assisted interpretation of growth.
To move one step forward, we decided to combine all 3, like growth chart, pivotal status, and the bone age assessment into this big, which is the bone age assisted interpretation of growth. This is a very user-friendly web tool. This is not a mobile application. This is a web tool. Here, what we have to do, we have to just enter the key anthropomorphic parameters like weight, height, parental height, date of birth, and the pubertal status, which is done by the selection of specific image, as you can see for the breast, pubic hair, and also you have to click for the menarche status as well. Now, the second thing is to input the bone age. It could be done by the selection of 5 important sites that Sir has discussed. And the second method, you can manually input. You can manually input the bone age as well. So all these data is assessed and processed by the algorithm that has already been uploaded in the web tool, and which provide the instantaneous guidance on a single click as a pictorial growth chart that shows the mid-parental height, bone age, and weightage, along with the detailed interpretation of the growth parameters like BMI SDS, target height SDS, corrected height SDS, height SDS for bone age, corrected height SDS for bone age, which are very important for the classification of the growth disorders, along with the bone age report. And the most important thing, it gives the most likely diagnosis, like for the growth interpretation and the puberty, along with the workup that has to be done in a particular scenario. It also provides the follow-up tracking, which is a unique feature of this application. So when we did the validation, we found that it was concordance in about 99% of the cases. And we see that it has shown a much better concordance as compared to the pediatric endocrinologist, pediatrician, and pediatric trainee. It has increased the concordance rate to about 96%. And the impact of the discordance, what we have seen this, it decrease the mispathology to 20% and the unnecessary burden in 20.4%. The errors that we was found was normal puberty was diagnosed as the short or the precocious puberty, and the overdiagnosis of endocrinology etiology by the pediatrician and the pediatric trainee. The big has shown the reassurance and the follow-up in around 54.8% cases, and it has shown the misdiagnosis in only 6 cases. So we have this case of 12-year-old girl. The height is 132 centimeters and weight 20 kg. Father's height 163 centimeter and mother's 150 centimeters. As we know, the basic approach is to plot the growth chart, and what we can see her height is below the 3rd percentile, and if we see the mid-parental height, it is around 151 centimeter. The first question is to answer whether the child is short for the population or not. We can see it is below the 3rd percentile, so definitely it look like this is short for the population. But the second question comes whether the child is short for the family or not. If we see the curves that the child lies within the upper and the lower limit of the mid-parental height, that means the child is not short for the family, but it is short for the population. And if we see for the height age, and which is 9 years, and the weight age, which is also 9 years, and it is lesser than the chronological age, which is 12 years. And if we put all these data in the app, it will show that the child is likely to be the familial short stature, along with this chart with showing the BMI, height, and the weight. And here we can see the corrected height SGS is more than minus 1.6. That means that shows that this is the familial short stature pattern, not the endocrine or the other. Now coming to the second case, we have this 12-year-old girl with height 120 centimeter and the weight 15 kg. Mother height was 157 centimeter, father's 170 centimeter, and bone age was 10 years. Here the hemoglobin was 10.2, TSH and TTG was normal. When the IGF-1 level was done, it was 15 nanogram per ml, and the growth hormone basal level was low. So the question is whether this child has a growth hormone deficiency or not.
So do you agree with GHD diagnosis in this case?
Definitely not. So we cannot rely on the single level of the growth hormone, basal growth hormone level. So here we can use our app to say whether it is growth hormone deficiency or not.
If we look at basically the key outputs that we look at is the weight. So the most important thing to look at in a child who is short is to look at the weight. So what we see here is that the BMI SDS is minus 3.7. And we have said that if your BMI SDS is below minus 1, then we are dealing with most likely a nutritional cause rather than an endocrine cause. So based upon whatever we discuss, whatever Vibha has been talking about in the last 10 minutes or so, it's all incorporated in the app. It will give you the likely diagnosis. It will give you more precise figures. So the key message is you could plot on the chart to get the same information, but here you are getting more objective information in form of growth interpreter. Yeah, carry on.
So as the BMI SDS is minus 3.7, so definitely it is, and when the IGL level was done, it was indetectable. So definitely it is a nutritional pattern of growth failure. Now coming to the next question. Here is a 10-year-old boy with a height of 100 centimeter and weight 18 kg. His mother height was 150 centimeter and father was 163 centimeter. He has a pretty delayed bone age of 7 years, and hemoglobin was 13.2, TTG and TSH was normal, and TTG was 32. He was put on gluten-free diet, but there was no effect.
So do you agree that this is celiac?
With the level of TTG32, definitely not. And if it is a celiac, then definitely on a gluten-free diet, the height should have improved.
And the other thing would be the BMI.
BMI.
So what was the interpretation then?
So if we put all the data in the interpreter and we see the BMI, the BMI is more than minus 1.1, it is 0.6. So definitely it is not fitting into the criteria of nutritional pattern. And if we see, yeah, if we see the corrected height, this height SDate, it is minus 5.68 and the corrected height SDate is minus 4.27. So it means this patient is lying in the more in the endocrine pattern of growth failure, not in the nutritional one.
BMI is 0.6,
0.6,
which again suggests that this is an
endocrine pattern. So definitely this is not a case of celiac disease. Moving towards the next case, we have the 16-year-old boy whose height was 167.5 centimeter and weight of 127 kg. And we know that obesity is common. It is 5% of all population coming to our OPD, and most of the 98% are the physiological ones. Only 2% have pathological obesity. And so we should carefully assess them and manage them accordingly because most of them are physiological ones. So to avoid unnecessary workup, we should take cautions while doing the assessment. In the obesity, we have to see whether it is the physiological or the pathological. 98% is the physiological, and when it is physiological, the growth should be normal. They have a normal puberty and the development should be normal. Then it only lies under the category of physiological obesity. And in the pathological, we have genetic, secondary, and the endocrine pattern. If we see into the genetic, they are monogenic syndromic. They have the characteristic feature of hyperphagia. They have vision abnormality and their puberty is delayed. And if we see the hypothalamic or the drugs, the secondary causes of the pathological obesity, they have a feature of hypophagia. And if we see the endocrine causes of obesity, like the hypothyroidism, growth hormone deficiency, Turner's, Cushing, and pseudohypoparathyroidism, they have a growth delay and also the puberty delay. So we have this obesity interpreter, we have validated it, and what we have seen that it has shown a higher concordance rate. And first we see what fits the obesity criteria. That is, if the weight is more than 97 percentile, then it is obesity. And if it is not, then no workup is required. And if it is yes, then we have to see what is the age. If it is less than 5 years, then we have to see what is the BMI SGS. If it is more than +3 standard deviation, then definitely we should go for the genetic study. And if it is less than +3 standard deviation and the age is more than 5 years, then look for the syndromic features. And if there is difficulty, problem in the development, vision abnormality or facial dysmorphism, so definitely we should go for the genetic study. And if there is no vision abnormality, development is normal and there is no dysmorphism, then look for the height SDS. If the height SDS is less than minus 0.5, then definitely the endocrine workup should be done in these cases. And if the height SDS is more than minus 0.5, then the complication screenings is required, like lipid profile, glucose workup, and the liver function test. So if we see the obesity interpreter, we have to put the data, the weight, the height, and age, and it will give the BMI SGS. And we have to answer whether the development is normal, puberty is normal, and it will give the likely diagnosis of the pathological obesity, and it will also recommend the workup that is required in the particular cases. And when we have validated that, we have seen that 92% of the cases that have come to our OPD are physiological ones, and only 7 have the pathological obesity, and 1 are the genetics. So we see there was a high concordance rate of this obesity interpreter of about 99%. Now we have this 12-year-old boy with a height of 160 centimeter, weight 70 kg. His mother height was 150 centimeter, father was 163 centimeter, and bone age was 12 years. TSH was 7.91. And so the question is whether the treatment should be started in this case or not. If we put all these data in our interpreter, we can clearly see this is a case of obesity, this is a physiological one, and no workup is required in this case.
Again, we are looking at the height SDS. So
Yes.
what we found out that if your height SDS is more than 0 in the normal range, then the chance of pathological obesity is much less. And this TSH is, as we have discussed so many times, it's just part of the normal phenomena response to obesity. It is the effect of obesity, not the cause of obesity. And what's the course in your study that you're doing subclinical hypothyroidism? What happens to them on follow-up?
So what we have seen that not only the obese children, if the child is lean, then also there is a this remission rate even in the TPO negative patients.
So most of them will remit. So don't need to treat at this point of time. And this is not explaining the obesity.
Yes, sir. So we have a next case of 12-year-old girl. Height was 130 centimeter and weight was 58 kg. All the screening tests were normal and she was reassured and sent back to home. But there was a rapid weight gain in due course of time. As we can see, the height is below third percentile and the weight is the weightage is more than 50th centile.
So do you agree that this is a exogenous obesity?
No, sir. Here the in exogenous obesity, the height age is more than the weight age. Here we can see the child is short and plump. So definitely this is not a pathology, this physiological obesity.
So the most important thing to look at in an obese child is the height. The most important thing to look at in a short child is the weight, which will help you categorize into two different.
And if we see what the obesity interpreter gives us the result, the BMI SDS is 3.4 and the height SDS is minus 2.5, which clearly gives the child is short and plump, and the likely diagnosis is the pathological obesity. And definitely in these cases, we have to go for the workup. And when we did the workup, the FT4 was 18 and the TSH 0.24. So definitely it is not the Cushing one. It is so it is definitely not the hypothyroidism. It is more looking like a Cushing syndrome. And when the overnight suppression test was done, it was suppressed. It was 154. So definitely this is a case of pathological obesity, more likely the Cushing syndrome. Thank you.
Thank you, Vibha, for covering, and congratulations for presenting the BIG, which is our new tool at European Society of Pediatric Endocrinology. And we hope to come up with the tool in a couple of months, which will help out from there. So we've talked about growth, the most common presentation to a pediatrician from an endocrine perspective. We'll talk a bit about glucose disorders. So when we talk about glucose disorder, the most important, of course, is the management of diabetic ketoacidosis. And we know that when we talk about diabetic ketoacidosis, there are multiple aspects of treatment, but the first treatment, of course, is in the form of fluid. And as soon as we give fluid, we would be able to decrease the counter-regulatory hormones and dilute the overall plasma to decrease the blood glucose by around 100 to 200 milligram per DL in the first hour. Then we have to start insulin to correct for in terms of the correction of diabetic ketoacidosis, correction of other parameters. So these are the two major things to look at. But giving too much insulin is going to be hazardous. It is going to cause hypokalemia. Giving too much fluid is going to cause cerebral edema. So we need to be cautious about in that perspective. So both of them have to be monitored. If you give too much fluid, as I said, cerebral edema and hyperchloremic metabolic acidosis, too much insulin will cause hypokalemia. There is a phase-wise management of DKA, and SPAD has laid down wonderful guidelines, which all of us should follow, in which we have got the first phase in which we just give fluid, the second phase in which we give the fluid over 48 hours and add insulin, and finally, we add dextrose when the blood sugar becomes less than 300. Soda bicarbonate should be avoided, and beware of cerebral edema is something which is important. So in the initial 24 to 48 hours, we want to give maintenance and deficit using the standard formula, and we correct these aspects over a 48-hour period. Do not give too much fluid and always deduct the boluses which have been given in that perspective. And we can think of alternate solutions which can be of help in that regards. Monitor for sensorium, hydration status, and urine output, because oliguria and renal failure is an important problem here. Sodium levels should remain stable, potassium should be normal, and acidosis and ketones should improve over time. If the serum potassium is less than 3.5 right at diagnosis, we have to add potassium in the fluid, defer insulin, and think of potassium infusion. If it's between 3.5 to 5.5 or 6, we have to add potassium in the fluid, and more than 5.5, avoid in that regards. If a child develops polyuria, myopathy, think about a possibility of hypokalemia. Intervention is potassium infusion, reduce insulin dose, and consider magnesium, particularly if somebody is malnourished and there is celiac disease in that perspective. Once the blood sugar becomes less than 300, add 5% dextrose, becomes less than 200, add 10% dextrose, because we will take more time for acidosis to resolve. Bicarbonate should not be given, and if there is persisting acidosis, first exclude whether decay has resolved or not, then exclude your hyperchloremic metabolic acidosis along with lactic acidosis. So anion gap or a chloride load will give you the correct diagnosis in that perspective. If it's a hyperchloremic metabolic acidosis, which is very common on treatment, it will improve. Do not continue your insulin in that perspective. Bicarbonate causes a lot of problems like CNS acidosis, hypokalemia, and lactic acidosis. It should be avoided unless there is life-threatening hyperkalemia, hemodynamic instability, and give it as an infusion in that regards. Be wary of phosphorus. If you have a very severe decay, start with potassium phosphate as half, and if there is altered sensorium, myopathy, or rhabdomyolysis, think of a possibility of hypophosphatemia in that perspective. So as discussed, if you give too little fluid, you will have dehydration. Too much fluid, you will have cerebral edema. If you give too little insulin, you will take more time to settle. But if you give too much insulin, you will have hypokalemia. So any day, I would prefer somebody to stay in the ICU dehydrated for some more time than to die because of hypokalemia or cerebral edema. So this is what we want to do, is to go slow. Now, this is all theory, but when we actually looked into our own data as to what our people were doing, the intensive care physicians, they do in the immediate first hour of treatment, we found a lot of errors despite so many classes, despite a written protocol. There were around 82% records had an error. And these error could be that bolus was not given properly, the insulin dose was wrong, sometimes dextrose was not initiated, potassium was not initiated. And these errors could have prevented 32% of hypoglycemia, 58% of hypokalemia, and 34% of dehydration. So despite a good amount of exposure, a lot of errors happen. So what will happen in situations wherein the resources are not available? And this triggered us to development of our diabetic ketoacidosis guidelines, which basically uses the tools and the guidelines largely from ISPAD to implement it on a personalized basis. So I'll now invite Dr. Alapan to start off with the case scenario and how does it go forward from there.
Thank you, sir. So I'll start with a case. A 10-year-old child presented with blood sugar of high blood sugar level 540, weight of 30 kg. She has severe dehydration with a pH of 6.9 and dehydration almost 10%. Pace excess was -18.
So how will you like to manage this child? Will you manage in the ICU or will you manage in the ward?
In this perspective, this child is having a severe decay. So we'd like to manage this child in ICU, obviously.
And would you like to, how much fluid will you like to give, correct, or how much time?
We'll like to go for a slow correction in this scenario because is severe, the acidosis is severe. So too much early correction would cause increased risk of cerebral edema in this scenario.
Okay. So how will you go about? So let's go.
So initially, okay. So
if we go on to put all the data, so what we had discussed with Alapan, now what the app tells you is that whether this child has decay or not. So decay is there. Now you talked about initial bolus. So initial bolus should be there.
Yes.
What about the potassium? So 5.8 to 6, we can think of adding potassium. Now some guidelines say 5.5, some say 6. So we can vary, but this you need to give a potassium. The correction is at least over 48 hours, as you said. If there are features of cerebral edema and diagnosis, you may consider over 72 hours. Start insulin, and it gives what to monitor. So this is exactly the ISPAD protocol we have come out here, which will give you how to go forward. Carry forward.
Moving on to after 8 hours of the monitoring, the blood sugar came down to 180 from 540, and the base excess was also reducing. It is -18 to -12.
So what do you think should be done here?
So
the child is better, his sugars are better, let's stop insulin?
no, in this scenario, we have to remember that once the acidosis doesn't correct, we should not stop insulin in that infusion, and the blood glucose level will not be a cutoff for stopping the insulin infusion.
So this is a very common mistake that people decrease the insulin or stop the insulin. Let's say how the app works. Now, this is the second scenario in terms, no. Okay, just one second. So this scenario basically, you got forward. So this scenario basically we put all the data, and what it tells you based upon this is now that you should add dextrose. There is inadequate urine output. So it's looking at multiple parameters. The urine output is less, it will say check for renal failure. You want how much urine output usually? Minimum.
More than 1 ml per kg.
So 1 ml per kg per hour, and then you have to think of cellular edema. So if the corrected sodium falls, watch for cellular edema. So there are multiple small triggers which are there which may miss out if you don't put all the data, which the app will be able to identify that in that regards. Now at 20 hours, now the child is much better. His sugar is 212 and base X is still -12. So what do you think is happening here?
So we have to see whether this acidosis is due to the ketoacidosis or whether it is due to the hyperchloremic metabolic acidosis. It could be because we have given so much NaCl in that scenario. That could be one possibility here.
So how will you distinguish the two?
We'll look for the chloride load in that
Chloride
scenario.
load and gap, lactate, they will help you out. Now the difference between the previous scenario, 8 hours, I don't expect acidosis to go up. 20 hours, it should go up. So here I want to be more proactive. Otherwise, we'll continue to treat. So let's see what the app does here. You put all the data that is there and it says now, probably don't worry about this -12, ketoacidosis is resolved. Then you start thinking of it. It also gives you how much insulin dose is to be suggested based upon the DKA and the child being pubertal, pre-pubertal, you will get the data on that. Now, the next scenario.
The 16-year-old boy presented with osmotic symptoms of polyuria. Blood sugar is high with a high HbA1c of 10%. She landed up into ICU with DKA and required insulin in that scenario. But the treating physician has found that the child is obese. He has family history of type 2 diabetes in his family, and some signs of acanthosis nigricans in terms of insulin resistance were there. So he considered this child as a case of type 2. He stopped insulin and advise child the metformin in that scenario.
Do you agree with this? You see now a lot of patients who are obese, have acanthosis, have this diabetes. Do you think he's right? And can DK happen in type 2 first of all?
Yes, DK can happen. 5 to 10% patient with
so
type 2.
Do you think he was right?
I think before considering or labeling someone as type 2 diabetes, we should always look for the antibody status in the child. Ideally, 2 antibodies should be present to call it a type 1. If antibody is negative, then we can consider for the type 2 diabetes in this scenario.
Yeah.
So look at the guidelines, what ISPAD has said in 2022, that if even the symptoms of hyperglycemia and values more than 126 of fasting, 2 hours more than 200 and HbA1c of 6.5, if you have to consider for a islet cell autoantibody, if islet cell autoantibody is negative, then only you can say this is a case of type 2. Otherwise, you have to always consider for the type 1 diabetes.
So this is the very important. The default diagnosis in pediatric diabetes, even in this day and age, is type 1 diabetes. If you are antibody negative with low requirement, then think of type 2 or MODY in that perspective. In our experience, how many are type 1? What percentage of 10 to 18 will be type 1 versus type 2?
Almost, sir, 75 to 80% will be there in type 1.
Even between 10 to 18, around 75% will still be type 1 diabetes. And do you see obese type 1 as well?
Yes, we used to see a lot of obese children because the lifestyle modifications were not there even in the type 1.
So this obesity is not a very important criteria for type 1.
So as we move forward in this case, the child was GAT positive. So eventually a case of type 1 diagnosis, type 1 diabetes, which was mislabeled as type 2 diabetes. So we often see this case kind of misclassification in our practice where type 2 are labeled as type 1 or type 1 was labeled type 2. So insulin was further continued in this case. So type 1 diabetes, it is very common in children population, and almost 80% cases among all the diabetes population are type 1. Type 2 is C in 15% cases, and rest of the cases are MODY or other genetic causes of diabetes they are present. So a child with type 1 diabetes, when to consider that this could be another possibility of MODY or another kind of diabetes. So if in a case of diagnosis, in a case of type 1 diabetes, if there is no insulin need, even after 1 year of diagnosis, the C-peptide level is detectable. There is a family history of diabetes in the patients, and the first degree, at least 3 generations were positive for diabetes, and there is a negative antibody. Then we should consider for the other diagnosis like MODY in a case of type 1 diabetes. At the same time, a diagnosis of type 2 diabetes, if there is no obesity, no acanthosis present, we should always consider for the other kind of diabetes. And as already sir has discussed that calling a patient as type 2, you should always have a negative islet cell autoantibody. So if we classify 3 types of diabetes, the type 1 diabetes can present at any age, but it is usually we have seen the peak age is around 5 to 15 years of age, while the type 2 we often see around the pubertal age after 10 years of age or something like that, and MODY can present even before pubertal age or after the pubertal age. If we consider the family history, the type 1 doesn't have that much family history, but there is a strong family history in cases of monogenic diabetes, maturity onset diabetes of young, where almost 3 generations of are affected in diabetes. In if I see from the obesity perspective, the type 2 diabetics are much more obese, but the type 1 MODY and MODY can be also obese, but it doesn't has a percentage because it is almost equivalent to the population prevalence. The severity, if you can see, the type 1 has much severe cause, can land up into type 1, but any patient coming to decay in our ICU setup, we should not label them as type 1, as some cases of MODY and type 2 can also have diabetic ketoacidosis. Ketosis is usually present in cases of type 1, and autoimmunity is almost a diagnostic of type 1 diabetes, but some cases are there where 10 to 20% cases of type 1 could have a negative autoantibody screening, while some MODY and type 2 have autoantibody positive screening. There are some HLA associations that are common in cases of type 1 diabetes. And if we go for the fasting C-peptide level, which is a marker for insulin reserve in our body, we can see the type 2 has much more insulin reserve in comparison to the type 1 and the monogenic diabetes. So there are some autoimmune type 2 diabetes are there where there is low beta cell reserve, and there are features of less metabolic features like no obesity, less signs of insulin resistance are present, and there is a need for insulin in this child.
If you have suppose labeled somebody as type 2 and there is a associated antibody which is there, will you treat him like type 1 or type 2?
We have to see for the course as well as the severity of the diabetes.
So even if the antibody is positive, will you still consider type 2?
No, it can be, sir. It can be
LADA
type of presentation.
Then you manage it like type 1,
Type 1,
basically.
yes. So our so there is a need for a point of care tool which will correctly classify diabetes, because the improper classification often lead to missing of type 1 decay like presentation, which can land up the child into ICU. So our application is based on this algorithm, which is taken from the SPAT 2022 guidelines. In these guidelines, we have seen that if the child is below 6 months of age, we consider genetic study and we consider them as a neonatal diabetes. In the age group of 6 to 12 months, if antibody is positive, then only we consider this child having a type 1 diabetes. In age group more than 10 years, if a child does not have any decay, is an overweight child and a negative autoantibody, then only we can consider for a type 2 diabetes. Otherwise, when the insulin requirement is less than 0.5, after 1 year of diagnosis with a negative autoantibody screen, we can consider monogenic diabetes. Rest all, we'll have to consider type 1. We have to manage like type 1 because we don't want to miss out the diabetic ketoacidosis in children.
So the interpreter basically is looking at age at onset, duration of diabetes, how much insulin need is there, and what is your BMI. Just 4 things. And then based upon 4 things, we are trying to classify. So we need to understand that there will of course be some limitation, that if you have some syndromic features that you have to see examine, If you have some other specific features of secondary diabetes, as we were discussing, is going to be difficult. But if you want to have a ballpark figure by using just 4 parameters, we are able to classify. Like in obesity interpreter, we talked about BMI, we talked about height, growth, development, and vision. And then we try to classify. So same is the diabetes interpreter. So how does it work and what have you found in your validation study?
Yes. So based on this, we have developed the app of diabetes interpreter and validated it. It is a mobile application based tool. We have seen it has a higher concordance with the gold standard. Gold standard is a senior pediatric endocrinologist having experienced more than 25 years of age. And we see the gold standard and the diabetes interpreter has a concordant rate, as well as the pediatric and adult endocrinologist have a similar kind of concordance rate in terms of diagnosis as well as suggestion. While in comparison to them, the pediatric trainee and the pediatrician have a much lesser concordance score in terms of diagnosis as well as the recommendation. So if we can see from here, the pediatrician and the pediatric trainee has advised for workup when it was not needed in 42% and 43% cases, which was much higher in comparison to the diabetes interpreter as well as the pediatric endocrinologist. So we can see a lots of unnecessary workups there has been advised, and this workup increases the cost of burden in the families of the type 1 diabetes, and we want that to decrease that cost. Not only that, there is also some misclassifications that are present. We can see the adult endocrinologist had diagnosed 30 cases of autoimmunity, almost 4.97% cases, without advising autoimmunity in that, diagnosed type 2. So in these scenarios also, as ISPAD had clearly mentioned, that before labeling someone as type 2, we should always consider for the default mode, that type 1, and we should consider for the genetics autoimmunity screening. Not only that, if we see from the type 2 perspective, we can see the adult endocrinologist had correctly diagnosed most of the cases of type 2 diabetes in comparison to the pediatric endocrinologist and the trainees. So the adult endocrinologist who is expert in type 2 is diagnosing more cases of type 2 while he is not doing GAD antibody in suspected cases of type 2. So here lies the importance of our application in the clinical practice, where the application could correctly guide you regarding the diagnosis. Not only it will recommend the treatment where the workup is needed and where it was not needed. So if we see our case, which are previously discussed, a child with 16-year-old polyuria having a blood sugar of 440 and HbA1c of 10%, initially admitted as DKA and having a BMI of 2.2, that is in the obese group, now requiring 10 units of insulin per day. If you see our interpreter, let's see what it gives. So it has recommended in its first line that recommend GAD antibody. Before labeling someone, please recommend a GAD antibody. If GAD antibody is present, then we can consider for the type 1. Otherwise, it could be a case of type 2.
Which you're looking at is this is more than 10 years of age. Follow-up duration is more than 1 year.
Yes.
And the insulin dose is less than 0.5. So this means that this is an insulin replete individual who is obese. So now clinically you will think of type 2 diabetes as a possibility. But yes, as Alapan has illustrated, GAD or any autoimmunity should be assessed in that regards.
So moving on to the next case, 11-year-old girl, routine investigation were done and seen the fasting is on the pre-diabetes range, and prandial, postprandial range was also in the pre-diabetic range. She has a lean thin individual and BMI of 19.2 with no features of insulin resistance present. HbA1c is on the borderline, again 6.4 with no ketosis.
So what do you think, Alapan, in a lean child who comes to you with this sort of a picture, pre-pubertal child, whose fasting is reasonably high, post-parental is not very high. Do you think this is type 1, type 2?
Sir, unlikely this case is a type 1 because the fasting level is high and the postprandial is not high. Doesn't have that much signs of any other insulin resistance. So clearly the type 2 perspective is out.
So type 2 is extremely unlikely. Type 1, you can say, okay, this may be a very early diagnosis of pre-diabetes you have diagnosed. But what is more likely? If you think of this biochemical picture,
this is more likely a case of monogenic diabetes, especially GCK defects, because the fasting levels are higher in this scenario in comparison to the postprandial levels.
So your glucokinase is not working if you have basically a fasting level, and once the levels go high, they start working. So that's why this delta increment is much lower in that regard. So let's put on the app then.
So she was GAD negative, and see what our application gives in this scenario.
So this
So
is saying recommend
GAD
GAD antibody and targeted panel for MODI if negative. Now this you can also get if you take a good clear history that the mother also has a similar
Similarly.
pattern, maternal aunts also had the problem in this girl. So this is there. So if you are expert, you can judge it. But if you're doing your routine and not seeing that many patients, you may miss it out. That is the message from there. This turned out to be a glucokinase defect.
Yes. So moving on to the next case, a 2-month-old boy presented with failure to thrive. Birth weight was initially 2.5 kg. Now it's 2.8 kg. He has hepatomegaly, myopathy, weakness. Blood sugar is sky high, 487 with HbA1c of 9.9 and high TG level. So he was advised glargine, a long acting, and lispro, a short acting insulin in that scenario. So let's see what our application gives in this regard.
So what do you think according to you?
This is a 2-month-old child, so neonatal diabetes should be a consideration in this scenario. We should look for a genetic study.
You have to think of a targeted panel clearly in this scenario.
So moving on to the hypoglycemia.
So when we talk about hypoglycemia, we need to understand that there is a spectrum of disorders which are there. The most important thing to look at in the setting of hypoglycemia is ketone level. Everybody who is hypoglycemic should be ketotic. If the ketone is not there, then we're dealing with hyperinsulinism, fatty acid oxidation defect, or galactosemia in that regards. Second is lactic acidosis. If your lactate is present, you are specifically looking at glycogen storage disease or a gluconeogenic defect. If there is acidosis, then you add organic acidemia in the differential, and insulin should be undetectable in anybody who has got a scenario of hypoglycemia, and then glucagon test. So mostly what we're looking at is the ketone, lactate, and insulin. And when we discuss about the interpreter with Alapan, we'll talk about only these 3 parameters. So this is what you need to really understand. What we also need to understand is what is the physiological response to hypoglycemia. If your sugar is below 50, you should have no insulin. You should also have a ketone which is more than 2. You should have a cortisol more than 550 and a growth hormone level more than 10. So this is a normal response. So when we talk about critical samples, you have to take these critical samples to interpret and get the result, and lactate should be low, and any detectable insulin becomes hyperinsulinism. Non-ketotic becomes hyperinsulinism, fatty acid oxidation defect, and galactosemia, and high lactate suggests GSD1 and gluconeogenic defect, while cortisol deficiency will suggest MPHD. Other important thing to remember is that there is a physiological dip in glucose level in the first 24 to 48 hours. After 48 hours, a neonate will behave as if they have a normal adult homeostasis. So within the 48 hours, you can have a lower sugar levels. So we need to talk about operational thresholds. Less than 25 milligram per DL in the first 4 hours, less than 35 in the 4 to 24 hour, then 50, and then 60. So we need to understand that a lot of unnecessary workup is done when we are not following these cutoffs and thresholds in that regard. So just to summarize the approach, if ketone is low or absent, look at reducing substance. Positive, galactosemia or fructose intolerance. Negative, look at insulin. Undetectable insulin, fatty acid oxidation defect, detectable hyperinsulinism. If somebody is ketotic and lactate is high, we have GSD1 or gluconeogenic defect. Normal, look at organomegaly to identify GSD3 and 6, and then look for growth hormone deficiency or go to accelerated starvation. So essentially, this is what we have put in our hypoglycemia interpreter, which is part of this next generation app. And if you have hyperinsulinism further, we have also included this. If the hyperinsulinism is there, first of all, give dextrose and diazoxide. If there is no diazoxide response, then you start thinking of refractory causes. Consider a genetic study for a potassium ATP channel defect. If there is a recessive defect, it's a diffuse disease, surgery is required. If it's a paternal defect or Beckwith-Wiedemann syndrome, then you can do a fluorodopa PET. So these 2 algorithms is what we have interpreted there, and we'll start off with the cases.
So 3-hour-old girl child presented with a blood sugar level of 35 milligram of DL.
So what do you think? You have been referred.
So if we see the cutoffs, so in the first 4 hours, we should the blood sugar level less than 25. So we'll not consider it even a case of a
So you will look for
hypoglycemia.
symptoms and you will say, okay, continue, encourage feeding
Feeding,
and
yes.
other things. Then let's see what the app does. So the app has got neonatal arm and the post-neonatal arm. And so basically, if you look into this, if you go into the neonatal and you put the data, you have to tell how many hours is the child, and then you enter what is the glucose level. You're saying 35, and it will say normal, no need for workup. It doesn't mean that you don't reassure in terms of feeding, another perspective. Now, second scenario, now we come back, 28 hours, blood sugar is 44. Do you think this is significant?
Yes, this time I think the blood sugar is a bit lower from the threshold at least, and we should look for the symptoms whether it is present or not in this
So
child.
symptoms for hypoglycemia will decide. We'll like to work up.
I don't want to work up in this child. If you want to seek consideration of feeding trial initially, if it is not improving by 48 hours or then we can
So
think.
48 hours is the holy grail as far as when you want to start workup, because otherwise you will start workup in everybody. So what we are seeing here, glucose is 44. It's saying you have symptoms. Your symptoms are there. So then, because of symptomatic, it's saying that you can consider a dextrose bolus and start glucose infusion. So all the guidelines has come up out here in the easy perspective. Now moving to more complicated cases, 3-week-old boy with seizures and hypoglycemia. What would you like to look at here clinically?
Clinically, I would like to look the birth weight of this child. The
At 3 weeks?
Unlikely, but
so what else?
We can look for the maternal history, whether it is present or not. And we should look for the any stress full condition in the present in the child or not.
So he's come to, he was fine, he was discharged. He comes back at 3 weeks with hypoglycemia. So you have to think of some other things. So these are more for transient causes you're talking about. We should look for the liver.
Okay,
You should look for
hepatomegaly also.
infection. You should look for cataract. You should look for all the other features that we talked about in that perspective. So now, of course, ketone becomes important. Ketone is positive. And sodium is 128, potassium is 3.6. What do you think is happening here?
So this is a case of ketotic hypoglycemia. The ketone is positive, but the sodium is on the bit lower side. So we should look for the other pituitary hormones to see any pointers. The micropenis is there.
Micropenis also. So this is what the message is. So this is clearly a ketotic hypoglycemia. So if you put the age and you put the glucose level, what you're finding here is the glucose level here is low, of course, for the threshold. So 28 is low. We are looking at ketone. So it gives an option also if you don't have a blood ketone to put a urine ketone as well. And blood ketone is positive, then of course you will go do the cortisol. And 125 was reported as normal. Do you agree with that?
In the scenario, we should look for a contextual assessment. So in a case of 128 and a blood sugar of 28, cortisol should be much higher, like more than 500 or more than 550 in this case. So it will take, we'll take this as
so
a
with
low.
a micropenis, with a low cortisol, hypoglycemia, ketotic, and hyponatremia, your diagnosis will be most likely a multiple pituitary hormone deficiency. Now, another 3-week-old boy with failure to thrive, again hypoglycemia, but not requiring too much glucose. There is a hepatomegaly. What do you think of?
Here also, there could be a possibility of galactosemia, infection, any kind of, or hyperinsulinism also can cause this kind of hepatomegaly in the
So you
children.
would like to know about the
ketone level. I would like to see the
ketone is negative.
So
0.4.
we would like to see for the urine reducing substance before leveling someone as
so you can look at insulin or reducing substance, and that was suggestive of a galactosemia. So this is going to help you out in terms of diagnosis. A very common scenario, 14-year-old boy with birth asphyxia in the ICU, there is hypoglycemia. GIR is 14 milligram per kg per minute. This child requires evaluation?
Yes, because he is 14-day-old.
And now the ketone is negative and insulin is 4.2.
So there are some pointers like GIR is very high in this child. There is a birth asphyxia. The child was admitted in ICU and it has presented in around 14 days. So if ketone is negative, we should consider for the reducing substance. If it is negative, we should see for the insulin level. Insulin level here is detectable. So any detectable insulin level in setting of a hypoglycemia should consideration of a hyperinsulinism. And in the setting of birth asphyxia, we should always look for whether it is a case of prolonged hyperinsulinism.
So birth asphyxia with SGA, think of prolonged hyperinsulinism, and we can give a trial of diazoxide as we discussed. 3-day-old boy
Boy,
with
severe.
severe hypoglycemia, weight is 4,600 grams. GIR is very high. So what do you think is happening here?
Again, this is a large for gestational age child having hypoglycemia in a 3-day-old boy. GIR is too high for this child. So you'll consider a hyperinsulinism state in this child
So
also.
ketone was 0.8, insulin is detectable. Then of course we go for in terms of hyperinsulinism
Insulinism.
algorithm.
Yes.
So this is a LGA. So LGA would basically mean that it's unlikely to respond to diazoxide. And as we discussed in that algorithm, you should consider a genetic study for child and parents. That will tell you whether it's a focal or a diffuse form, and then you can plan therapy from that perspective. Now we go into older child, 1-year-old boy with seizures with hypoglycemia. Ketone is negative.
So we should always see for the insulin level in this case also. Insulin is undetectable. So we should see for the, and here the reducing substance is also positive. So
yeah, so it will go in favor of a fructose intolerance in that regard.
6-month-old boy presented with lethargy and blood sugar level is 36, a low blood sugar level, and ketone is positive. Lactate is higher on the higher side.
So what are you thinking of?
So it could be a glycogen storage disease in this 6-month-old.
GSD1 or fructose 1,6 bisphosphatase deficiency. You can think of a glucagon test and hepatomegaly. So if you just use these basic clinical parameters, you can make the diagnosis. Very common case, 1-year-old girl not waking up in the morning. Blood sugar is only 24. So hypoglycemia is definitely there. We should look for the ketone level. I think ketone is positive in this child, and lactate is not detectable. There is no hepatomegaly. So we'll look for the pituitary hormone deficiencies, whether it is present or not, and it is clearly showing there is no deficiency. It could be a case of accelerated starvation. So again, the message is, if you look at very simple parameters, the age, the level of sugars, what is the glucose infusion requirement, ketones are there or not, lactate, you will get the diagnosis, and the tool is there to help you out in that regard. So thank you, Alapan. And Alapan's work on diabetes interpreter has been presented at various places, and it's under publication also in that regard. So we have discussed about growth and glucose disorder, a touch about puberty, which again is an important thing. Now, precocious puberty is common in girls more than boys, but it is more likely to be physiological. Delayed puberty is more common in boys, but again more likely to be physiological. So if you have a boy with precocious puberty and a girl with delayed puberty, you are more concerned about the likelihood of a pathology. So precocious puberty in girls is defined as a pubarchy or thelarchy before 8 years of age and vaginal bleeding before 9.5 years of age in that regards. Look at the extent. If there is only pubarchy, look at DHEAS. If the DHEAS is low, this is only pubarchy, nothing much to worry. 40 to 135, look at adrenarchy. More than 135, look at CAH as a possibility. Only vaginal bleeding, normal breast, normal pubic hair, think of a local cause. Trauma, tumor, abuse. If you have complete puberty, thelarchy, look at the bone age. And if the bone age is retarded, think hypothyroidism. Normal, look at slowly progressive, and advanced, look at LH. And then you can decide. Now, these are so many parameters to look at. We have tried to simplify it using a puberty interpreter, which will really look at only a few parameters to give you a diagnosis. I'll invite Dr. Sandeep to join in as well. So we have a 2-year-old girl with thelarchy, onset 6 months ago, slowly progressive. What do you think is happening here?
So this is 2 years old girl, and thelarchy has happened and slowly progressive. So we should investigate further, sir.
So breast is stage 3, pubic hair is 1.
So this can be isolated thelarchy, sir.
And the height is also normal. So you want to further work up, or you want to wait for some time?
Sir, since there is only breast development is there, and there are no signs of macroalbumin also, sir, there are no capillary spots, then we can keep the patient on follow-up also, sir.
We can keep on follow-up or do a baseline workup in that perspective. So if you look at our interpreter, what it's saying is that you have to do the basic workup and then you can decide from that. Most likely this will be a slowly progressive puberty. So this is a slowly progressive puberty. You don't need to do much. What about this girl?
This is 6-year-old girl, sir. The present with thelarchy since 1 month, and height is 124, sir.
So you think she has true precocious puberty?
We need further input, sir, like
clinically. She is stage 3, she is 6 years. So this is most likely a rapidly progressive. She is tall also, for her age. So if you look at the other parameters, bone age is 11 years.
Bone
So
age
this is
advanced, sir,
definitely
most likely pathological progressive puberty, sir.
progressive puberty. So if you look at our analysis based upon the height and the bone age, we will find that we need to do workup in that perspective. So clearly the guidance would be based upon the bone age. Now, how do you define as advanced bone age? What is advanced bone age?
Sir, bone age more than like 120% of the
Height age.
height age, sir.
So if bone age is more than 120% of the height age, this is suggestive of a advanced puberty. Or I would say height standard deviation score, which is for bone age, which is less than -2. This is an important pointer. This girl at 6 years is not short. Her height is 1.74. But when you correct for the bone age, it becomes -2.64. So this, I would say, is the most important parameter which will help you out in terms of treatment. So the interpreter is saying that you would need to start treatment from that perspective. 6-year-old girl with pubarchy, birth weight is normal. Carry on.
The birth age is normal and she presented with pubarchy. Height is 132. Weight is 26 kg, sir. Pubic hair stage 3, breast stage 1, and there is no menarche.
So do you think this is significant or not?
Pubarchy stage is significant, sir. Each level is 3.
So up to stage 2, you may not worry. But if it's going 3 and beyond, this is definitely worry in that regards. Do you think this is just pubarchy, adenarche, or exaggerated adenarche?
So we have to investigate the patient, sir.
Okay, so
And,
clearly if you put the pubic hair and other parameters, it's saying likely precocious pubarchy. You have to do DHEAS, which is very, very important here. So DHEAS is 240. Testo is also high. So what do you think?
the DH is high and testo is also high, so we should go for 17 OHP and imaging, sir.
So we have to rule out a possibility of a adrenal pathology.
7-year-old girl presented with vaginal bleeding, and that was only one episode. And the pubertal status is B1 and PH1.
So what do you think?
So only bleeding with no breast development and pubic hair is more like it's likely a isolated vaginal bleeding, sir. And the vaginal mucosa is also red, so that there is no estrogen exposure, sir.
So if we say B1, P1 and periods, it is most likely isolated bleeding. You have to go for a gynecology referral in that perspective. Now, 7-year-old girl with thelarchy, do you think this is significant, this girl?
The thelarchy is significant, sir.
Okay, and the other thing we are looking at?
Her height is 100, which is like short, sir. Short for her age.
And she very recently had a vaginal bleeding as well.
And the breast stage is 3, pubic hair stage 1, and the vaginal mucosa is pink.
Okay, and this is the growth chart.
Growth chart, she's significantly short as for her age, and the weight is not that.
So what do you think? 7-year-old girl with menarche, thelarchy, very short, and this is the growth chart.
So, sir, she is having height is less for her age and for the level of puberty, and so we should investigate for thyroid function, sir.
So all girls with precocious puberty should be tall. This is a short girl. Think thyroid. There's a large ovarian cyst putting there. So this is a von Wieck-Grumbach syndrome, which is because of the effect of
TS is on the FSH receptors.
Yes. So this is clearly bone age is delayed. If you look at our app, put the data in terms of breast. And why is there no pubarchy?
Sir, because this is the local effect of FSH on.
Because TSH is high, TRH is high, prolactin is high, LH is low. So high FSH, low LH. So no pubarchy. And of course, bone age is delayed. How can you have pubarchy if the adrenals will not wake up at all? So this really based upon these parameters gives you consider hypothyroidism as a possibility in that regards. Now, management, of course, depends upon the age. Less than 6 years of age, most central will require treatment. 6 to 8 years, depending upon bone age, you will treat. You can think of GnRH analog, which if you give on a long-acting one, will desensitize the pituitary, and this is how it will work. The other option, of course, will be that you have to be very careful in terms of adherence. So if there is a gap between treatment, then you will have again recurrence which is happening. And we discussed about the monitoring. What is the best way to monitor according to you based upon the discussion we had that day?
Sir, for the best way is to look for clinical parameters like, sir,
Yes.
bone age and the pubertal status, sir.
Mhm.
And apart from that, we can go for the basal LH level, sir.
So basal LH or the LH 2 hours after the
After the
injection,
injection of
the agonist injection,
Yes.
the random LH doesn't have that much value in that perspective. So you expect an improvement in the breast development, improvement in bleeding, but not much improvement as far as pubic hair is concerned. Medroxyprogesterone acetate is one agent which can be considered in which group of individuals?
So those patients whom we are not worried about the pubertal status, we are worried about the bleeding, like patient with cerebral palsy.
So where the height is not a major issue, then you can give MPA only for a vaginal bleeding perspective. So we have got all the therapeutic options and details which are given as part of the app. Now in boys, we know that if you have an onset of puberty before 9 years of age, that is the early puberty, and the testicular volume will give you a cue. Both testes are enlarged, you're talking about central precocious puberty. If there is both testes are small, this is peripheral. If both are intermediate, which mean that the Leydig cells are big, but the Sertoli cells are not big, this is HCG dependent or a LH receptor problem. And one is big, this is more likely to be a testicular tumor. So this is a 4-year-old boy with early puberty with large testes. Do you think this is pathological?
4 year with large testes with early puberty is pathological, sir.
So boys anyways have a very high chance of pathology. So if you go by our own guideline, it will say that this is central precocious puberty and recommend MRI head. Now, if you go to our algorithm, then you go to the interpreter. If the girl is below 6 years, we would say do a MRI. After 6 years, only if the neurological features are there. But boys, every boy should have a MRI. What do you expect here in this MRI?
So for this level of puberty at this age with large testes and the LS level is high, sir. So it is likely hypothalamic hamartoma is there, sir.
So the most common cause of very early onset precocious puberty is the hypothalamic hamartoma, which is an abnormal location for a normal tissue. So it's a ectopic location of hypothalamus, which is not being regulated. Would you send to the neurosurgeon? This looks a very large lesion.
So there is no need of neurosurgery as such, and we should start with the generous agonist treatment, and we should keep the patient on the follow-up.
Unless it's 8 centimeter or above, it's causing some pressure symptoms, you don't need to do any surgical intervention. 7-year-old boy and the testicular volume is less in that perspective. And what do you think here?
When the testicle volume is less and there is early puberty, then it's most likely going to be peripheral one, sir.
So this is most likely a peripheral precocious puberty. And in this scenario, your LH-FSH is low, testo is very high. Which next test will you think of?
So then in this scenario, we should go for 17 OHP, sir.
So of course, 17 OHP becomes important because adrenal cause will be there. Look for blood pressure, look for pigmentation. So there is an adrenal hyperplasia, and always think of an adrenal tumor because that's also something you can be aware about. Can you have high 17 OHP in adrenal tumor?
Yes, sir, we can have, sir.
Adrenal carcinoma can have some elevation in 17 OHP, not this high, but yes. Don't just get misguided. Your 17 OHP is 10, 15, 20, that this is only CAH. Think of it could be adrenal lesion also. And we have missed patients with adrenal carcinoma. They may be indolent. They may have no other features other than precocious puberty. And then they will come to you with frank metastasis. So delayed puberty in girls is defined as breast which is not happening by 13 and menarche within 5 years. The workup basically determined based upon the screening test first. You have to exclude all the chronic systemic illnesses and then gonadotropin levels. If they are high, we are thinking of Turner syndrome. If they are low, we are thinking of a central pathology from that perspective. So you have a 16-year-old girl with delayed puberty, no breast, no pubic hair. She is short and she is lean. What are you thinking about?
So at 16 years, no puberty, breast stage 1, pubic hair stage 1, and she's underweight, sir. So we should look for the systemic causes, sir.
So before you do any unnecessary workup, LH is low, but it is expected to be low because your nutrition is not there. So if you look at the evaluation, you have to think of first systemic causes, and one important cause here would be TTG, which we identify, and she had anemia, clubbing, and happened to be celiac disease. 16-year-old girl with primary amenorrhea, a very typical scenario, stage 4 breast, no pubic hair. What do you think?
So, sir, 16 years old girl with primary amenorrhea and there is breast stage 4 with no pubic hairs. So we should look for androgen insensitive syndrome can be a possibility.
So if you look at primary amenorrhea, look at breast. No breast, that is delayed puberty. Breast development with hirsutism, that is PCOS. Breast development, no pubic hair, that is androgen insensitivity. And breast development and normal pubic hair is a local cause, like Mullerian agenesis. So stage 4 breast development, she is tall, FSH is high, karyotype clearly in this scenario is going to be XY. This is a classical case of androgen insensitivity syndrome. So our will give you a diagnosis in that perspective. For boys, delayed puberty is no testicular enlargement by 14 years or stall development. There is no role of pubic hair or penile length. Remember, boys usually are physiological. So 80% will be CDGP. Your main aim is to think of when this is not CDGP. So if you have a tall boy with pubic hair development, CNS feature, micropenis and stalled puberty, this is not CDGP. Then of course workup depends upon your testosterone levels and gonadotropin levels, and then you differentiate constitutional delay versus permanent HH using your testicular volume and inhibin B. This algorithm which we have put here is used as far as our interpreter for puberty is concerned. Mainly we are looking at TV and inhibin B. TV less than 1 ml, inhibin less than 50, think of permanent HH. TV more than 3 ml, inhibin more than 100, this is most likely a self-limited form of delayed puberty. So 16-year-old boy with pubertal concern, onset at 13 years, then stopped for 2 years. So do you think this is CDGP?
No, sir, this is not a CDGP because this is stalled puberty.
Yes, and the child is tall also, testicular volume is 1 ml, has pubic hair. So this is everything which is going against the diagnosis of CDGP. So this, if you look into our own application, what it is telling us is that this is most likely going to be a permanent HH for which you need to work up from that perspective. 17-year-old boy with pubertal concern, also at 12 years, now stopped for 3 years, testis is 2 ml and firm with gynecomastia, height is 182 centimeters. What do you think? A tall boy with gynecomastia?
Testis and stalled puberty. So it is going in favor of Klinefelter syndrome.
So this is a classical picture of Klinefelter syndrome. And again, FSH is high, karyotype is XXY. So this is classically Klinefelter syndrome. So this is the puberty interpreter which we have been showcasing for both boys and girls, including delayed puberty, precocious puberty, everything is evaluated and we found a very good score in terms of validation for this. Coming on to another aspect of the overall sexual development is DSD. And broadly speaking, if you want to look at DSD classification, look at two things: gonad and Mullerian structure. Any round structure which you can identify is usually a gonad, and Mullerian structure you can use either a rectal examination or an ultrasound. So if you have in a scenario where you have got only Mullerian structures, no gonads, this is
XXDSG.
yes. And then second scenario,
No gonads present and no Mullerian structures, it is XYDSG.
yeah.
And if both are present, it is AMS defect or O testicular degenesis. And in the fourth scenario, both are absent. It is mostly XYDSG with anorchia.
Rare case will be anorchia. So just by these two. So our algorithm starts off with both gonads and Mullerian structure. So if you have palpable gonad, absent, Mullerian structure is present, then you look at CAH or otherwise look at aromatase and dysgenesis. If you have palpable gonads with Mullerian structure, you're looking at AMH resistance or gonadal dysgenesis. If you have no palpable gonads or palpable gonads without Mullerian structure. So if the Mullerian structure is not there, what does it mean?
So XYDSG.
It means that sometime AMH was produced. That is why it is a XYDSD. So then you look at testosterone to then classify whether it is a combined biosynthetic defect, a defect in only the testis, or resistance to testosterone in the form of 5-alpha reductase versus AIS. So this algorithm, looking at palpable gonads, Mullerian structures, testosterone and 17-OHP, roughly 4 things, is going to guide your diagnosis in most cases. So we have developed a DSD interpreter, which we discussed earlier, is that in that regard. So we have a PADA4 individual with no gonads. What are you thinking here?
Since there are no gonads, PADA4 is there. So there is androgen exposure during.
So this is most likely a XX DSD. Uterus is present, 46XX. Now, if you go by our algorithm, the first thing it will ask is maternal virilization and 17-OHP levels along with the electrolyte. Now, 17-OHP is high. There is hyponatremia, hyperkalemia. So this is the most common case of salt wasting, 21-hydroxylase deficiency. Day 3 child, again DSD. So this looks like a PADA4 no gonad. This is again a
XYD.
XXDSD. but maternal virilization is present.
Yeah.
So what does it mean?
Aromatase deficiency.
So we have to think of aromatase deficiency or POR deficiency also in that perspective. So this is how you will be able to identify in that perspective. Day 14 child, you have got bilateral gonads, but no uterus. So this is a XY DSD with a testosterone which is detectable. So now you will start thinking of, okay, testosterone is there, it's not either getting converted or it's not going to work out. There's also hyponatremia with hyperkalemia and a high 17 OHP. What are you thinking here?
So since there are features of salt wasting with XY DSD, sir, so it is most likely higher defect, sir, like 3 beta SGs.
So yes, so you can think of star side chain cleavage if the testosterone was low. But here testo is not low, this goes more in favor of a 3 beta HSD. Final case, day 14 child, you can see clearly one side looks like a boy, the other side looks like a girl. So what is there in this case?
In this scenario, we have both uterus present as well as there are gonads. So it is like over testicular.
So you have to think of a over testicular DSD. So there is a asymmetrical genitalia. Look at AMH. If AMH is high, then you think of a different scenario. Low AMH means a over testicular DSD. So our DSD interpreter was validated in approximately 50 cases, and where we compared its diagnosis to that provided via the experts, the neonatologist, the pediatrician and pediatric trainee, and we found very high concordance for the DSD interpreter and a lot of discordance for the pediatric trainee. So this could be a tool which is going to help out in terms of improving the outcome in that regards. We have tried to cover 3 important scenarios. We'll now move forward towards thyroid. And thank you, Dr. Sandeep, for this wonderful discussion. And Dr. Vibha has been doing a lot of in terms of thyroid work. So she will be presenting the scenario from the thyroid perspective.
Thank you, sir. So, as we know, thyroid function test is the most screening test that we do usually in our OPD. So, TSH has a 40% diurnal variation and 50% interday variation, but it does not affect the interpretation. So, TSH can be done at any time of the day. T4 has a TBG effect, so always free T4 should be done. And T3 is of no use because it has MDI effect and it changes in lots of scenarios. So in case of hypothyroidism, the first thing that happens in the body is the increase in the TSH and decrease in the T4 level. There is also decrease in the T3 level, which happens at the last. So the most important investigation that has to be done in the hypothyroidism is TSH and T4. While in the case of hypothyroidism, the first thing to decrease is the TSH, then both the T4 and T3 are increased. And all the three, TSH, T4, and the T3 are the important and the useful investigation in case of thyrotoxicosis. So while interpreting the thyroid function, we know there is a log linear relationship between the free T4 and the TSH. When the T4 level goes down, the TSH increases, and if the TSH is above 20, that it means it is a case of primary hypothyroidism. And if the TSH is below 20, that means it is a case of central hypothyroidism. While when the free T4 increases, when it is high and the TSH is undetectable, this is thyrotoxicosis. And in case of high FT4 and detectable TSH, it is a case of TSH adenoma. So it looks pretty simple to diagnose the thyroid disorders, but in some cases like the central hypothyroidism, TSH adenoma, it is quite confusing. So we have developed this thyroid interpreter, which is available for 4 categories: the neonates, children, non-pregnant adults, pregnant adults. We have to enter the free T4, which is available. We can go for the nanogram per DL as well as for the picomole per DL, because we get FT4 levels in these 2 units, and we have to enter the TSH, and within a single click we'll get the most likely diagnosis. We have developed Mediclass's thyroid tools, the approach pathway for the congenital hypothyroidism, the acquired hypothyroidism, and the thyrotoxicosis as well. So if we see, the neonatal screening is very important, and it has to be done at the day 3 of life, because there is a TSH surge which starts at the birth, and the serum TSH is twice of the whole blood levels. So if the TSH at the day 3 is more than 40, so we have to repeat the free T4 level, and we should start the treatment immediately. And in case if the TSH is less than 30 and the space is if it is 34, if between the 24 to 48 hours, then no treatment is required in 99.9% cases. But if the TSH is between 20 to 40, we have to repeat the TSH after 14 days. And if it comes more than 20, then again repeat the free T4 and treat the child. If it is less than 10, then no treatment is required in this case. But if it is midway between the 10 to 20, then repeat again after 21 days and see whether the TSH is more than 20. And if it is, repeat the T4, FT4 and treat the case. But if it is between the 6 to 20, definitely we have to repeat the FT4. We should scan the thyroid gland and treat. We can wait till the scan, or if we want, we can start the treatment immediately. But if it is less than 6, then no treatment is required in these cases. Rescreening after 2 weeks of the birth is required in cases of prematurity, the children with trisomy 21, same-sex twin, and the children who were hospitalized during the neonatal period. So if you see, we have a day 4 child with a TSH of 22. At the day 13, it becomes 18. And if we see in the interpreter, if we enter the value, we have seen that at the day 13, if it is 18, it will show that it is a borderline abnormal thyroid screening. We have to repeat the TSH after 2 weeks of life and do the thyroid scan. And if it is above 20, we have to start the treatment. And at day 12, day 21, it was 11, and normal, the FT4 was normal. So we have seen that if the FT4 is normal, it is likely primary hypothyroidism, and we should consider thyroid scan in this case.
So I think this is very important that many milder sluggish cases may have some cause, which is like hemagenesis, which can be missed out. So we need to be cautious about in that regards.
So this was the case of hemagenesis, and a scan is to be done in these cases. We have this 10-day-old child with a TSH of more than 100. And if we see, the FT4 was 100, which was pretty low. On the scan, there was no thyroid tissue detectable. So the question is what to do here. The plan is we did the ultrasound, and there was eutopic thyroid. And on the history, we found that mother has hypothyroidism. So if we put all these data in the interpreter, what we have found, this is the approach pathway, and we see that it asks for what is the free T4 level. If it is less than 10.3, then it will ask what is the TSH, what is the finding on the nuclear scan, what is the finding on the ultrasound. Then it will get likely apparent athyrosis due to the maternal TSH receptor blocking antibody.
Important scenario in which absent scan is there. Now, this absent scan does not mean that there is no thyroid.
No thyroid.
So what are the other possible causes? One, we discussed about the TSH receptor antibody. What are the other causes of apparent athyrosis?
So other could be NIS, sodium imported effect.
Yeah.
And
It's
imported effect, and this TSH receptor defect. Yes.
And rarely iodine exposure, if it is there, that can also cause
Most check of
similar
10, yes.
scenarios, so which we have to be careful about.
So moving towards the approach of hypothyroidism, in the this we will first look what is the free T4 level, and if it is free T4 level is low, then we'll look for the TSH level, and if it is above 20, then definitely it is a case of primary hypothyroidism. But if it is below 20, then it is central hypothyroidism, and we should go for the MRI brain and the cortisol levels. And if the free T4 level is normal, and then we'll see the TSH levels. If it is below 6, normal, no need of any treatment or workup. And if it is more than 10, definitely it is a case of primary hypothyroidism. But if it is between 6 to 10, and we'll look for the risk factors like the TPO positivity, goiter, family history, and if it is a girl child or a boy. And if the risk factors are present, definitely we have to treat these child. And if there is no risk factor, then we have to follow up these cases.
So I think this is very important. We'll discuss that most children, whether they are obese or lean,
Yes, sir.
with 6 to 10 will improve. over time.
Improve on. Yes, sir. And now moving towards the case, we have this 12-year-old girl who presented with lethargy. Height was 140 centimeter and weight 36 kg. Free T4 was low, 6, and TSH was 9. So here, most of the pediatricians or the primary health cares make this error, and they label it as a primary hypothyroidism. So let's see what the thyroid interpreter says. We have to put the free T4 value, that is 6, and sorry. And in this case, the thyroxine was started from the pediatrician. And when we put all these data in the interpreter, it said that it is a case of central hypothyroidism, and the cortisol levels and the MRI should be done in these cases, and cortisol should be replaced before starting the thyroid.
So two situations wherein this, I would say three situations in which the thyroid interpreter can really help in the community practice. One is about the neonatal screening. A lot of people are unaware about what cutoffs to use at 0, 7, 14. So this is there. Second is this, even if we say one central hypothyroidism from being treated and going into adrenal insufficiency, that is important. And third, of course, is the thyroid nodule, which will come up later.
So coming to the thyrotoxicosis, definitely we should avoid for the nuclear scan if there is a goiter in the eye sign present, and if there is no, then nuclear scan is advised. And if there is increased uptake in the nuclear scan, it could be a solitary nodule. It will present like a small solitary nodule, like a localized lesion. And if there are multiple lesions, increased uptake, that it will be toxic MNG. And if it is a diffuse uptake, definitely it is a Graves' disease. And if there is a decreased uptake, tenderness present in the neck, so it is a case of subacute thyroiditis or the chronic lymphocytic thyroiditis. So next we have a case of 12-year-old girl who presented with tremor. FT4 was high, it was 34, and TSH was less than 0.01. There was swelling in the thyroid gland, but there was no eye sign. She presented with tremor. Now the question is what to do with this child. And when we put all these data in our app, we have seen this is the approach pathway, and it has asked many questions. What is the free T4 level? What is the presentation? And it will provide what should be started, what dose of the methimazole should be started, how should we follow up the case, and what are the adverse effects, and how long should we treat this child, and when the child could present with a relapse if we stop the child. So this approach pathway provides us so many information with the case with thyrotoxicosis and as well as the hypothyroidism.
This is clearly a case of Graves' disease, I think, from that perspective.
Yes. So we have a very interesting case of 10-year-old girl who presented with thyroid nodule. And on the USG, it showed that it is a 3 into 2 centimeter. It was firm, mobile, and TSH was 1.2, that is euthyroid. And on the ultrasound, it showed it is a solid cystic characteristic. The question is what to do with the child, whether we should reassure or go for the workup. When we put all this data in our app, we have seen that this interpreter has provided that the child should go for fine needle aspiration after 6 weeks and consider molecular study with a diagnostic lobectomy for the high risk cases.
So around 7 to 10% of all thyroid nodules in children will have malignancy. So if it's more than 1 centimeter with polycystic appearance, you have to do that. Problem is that there are specific ultrasound based criteria along with the clinical criteria which you have to decide, which are often missed out. Recently, there is some pediatric validation of the TIRADS criteria as well.
Yes, sir, they are doing, but they are not pretty sure whether they have to be applied with the pediatrics or not.
Yeah. So what we do in terms, this is the novel interpreter which we are putting in now, is the thyroid nodule interpreter. So what it is looking at, it is looking at TSH to classify into functional versus non-functional. Then it talks about the radiological appearance. If it's a non-functional lesion, in adults, we do our whole TIRAD scoring. In children, we just have a basic criteria as you discussed, and then decide whether FNAC is needed or not. So like this case.
So we have this 15-year-old girl who presented with the thyroid nodule. The size was 1.5 into 2 centimeter on the ultrasound, and it was firm and mobile on examination. And when we put this information in our app, it has shown that the TSH, when we put the TSH of 0.01 and the thyroid scan of worm nodule, we have seen that it is
So this will basically, so this is clearly a case of toxic
nodule.
And there is a warm nodule, which means that there is a risk of developing malignancy. So we should do a FNAC in this scenario. So if you're looking at TSH is
0.01 and the radio tracer uptake is worm nodule. Fine needle aspiration says then we have to go for the FNAC, and the interpretation says that we have to follow up after 1 year for size, and you have to follow the management for the thyroid nodule.
So these are largely based upon the European Thyroid Association and the
Yes,
American Thyroid Association guidelines. And adults, there is specific thyroid criteria. In children, it's not easily available. But I would say that this is a very good presentation overall. Thank Vibha for that. And so if you look at three major goals, I think one is neonatal screening, when to think of, how to interpret. Second, about central hypothyroidism. Third, about the thyroid nodule from that perspective. So we'll now move forward towards electrolytes, and we'll talk about three quickly. One is hyponatremia. So when we say hyponatremia, the most important thing to look at is the volume status. And the surrogate marker for volume is uric acid. If your uric acid is high, it means dehydration. If uric acid is low, this suggests a fluid overload or a SIADH state. Everybody with hyponatremia should have a low urinary sodium. If the urinary sodium is high, it is suggestive of a sodium loss. And finally, hyponatremia and hyperkalemia suggest a RAS defect in that regards. So all you have to do is to look at volume. If there is hypervolemia, the cause is apparent. If there is euvolemia, this could be SIADH, but think of hypothyroidism and cortisol deficiency. Exclude them. Okay, apologies for the disruption because of some technical glitches. So we're discussing about hyponatremia, and we're discussing about this interesting case, 1-year-old boy with hyponatremia and potassium is normal. So Dr. Sandeep, what are you thinking of?
Sir, we would like to know about the status of hydration, sir. So there was no dehydration. So there is no dehydration. We will look whether it is euvolemic or normovolemic.
So this is a most likely a euvolemic scenario,
The
and there is also hypoglycemia. So there is two things which are affected: sodium and glucose, which is ketotic. So you're thinking of a multiple pituitary
Pituitary
hormone
hormone
deficiency. But of course, you have to think of SIADH only after you've excluded these scenarios from that perspective. So this is a multiple pituitary hormone deficiency. Next case.
3 weeks old child presented with failure to thrive, and the sodium is 140,
110.
110. Birth weight is 2500 grams, and presently the weight is 2600 grams. Patient is dehydrated, and the PCB is 62. And if you put all this in our
So
interpreter,
clearly we have a dehydrated child who has hyponatremia.
hyponatremia.
Yeah. So what will you look further?
Uh,
So we have a child who is hyponatremic, urinary sodium is high. So
Urinary
this is
sodium is high.
look at potassium also becomes important.
So urine sodium is high, so it is definitely a renal defect, sir. So further evaluation will be done based on the potassium level, sir.
So potassium here was high.
High. So it is basically a RAS defect, sir.
So hyponatremia with hyperkalemia, most common cause here would be so the most common cause here would be clearly a case of a RAS defect, and most common cause in a boy who doesn't have any DSD would be 21 hydroxylase deficiency. We have a second child, 1 month old boy with reduced feeding. What we are seeing here, Dr. Sandeep, is that the birth weight has not regained. It's just 100-gram gain in a 1 month period, very less. Hyponatremia with hyperkalemia. So there is a salt wasting.
Salt wasting.
17 OHP is normal, cortisol is normal, but renin and aldosterone is high. So what are we looking at?
Sir, when the renin and aldosterone is high and 17 HP is normal in a scenario with hyponatremia and hyperkalemia, we should suspect pseudohypoaldosteronism.
And the most important thing to look at in pseudohypoaldosteronism first will be to go for a genetic etiology or something else.
We should rule out the UTI or obstetric causes.
Yes, so this could be a transient pseudohypoaldosteronism. So if we put all the data on the app, what we see it asks for creatinine. Of course, that becomes important. Creatinine here is normal. Subsequently, if you put the data, it is saying consider impaired aldosterone effect, and you have to think of the other pathway as well from that perspective. And there was a lot of infection and obstruction. So always think of a transient form of PHA before rushing to a diagnosis in that regards. So hyponatremic dehydration requires a lot of correction. There are formulas which are there. We have put out detailed videos on that to look at fluid deficit, how much is the sodium deficit, how much is the isotonic deficit, what's the maintenance, correction, and fluid. So this usually takes approximately 1 hour for me to explain, and often after that people tend to say we don't understand anything. So what we have done is that we have developed a very simple tool which will just guide you as to what is your sodium, what is your weight, will give you how much should be the fluid rate of 3% saline in that perspective. So rather than doing all that, you can simply use this tool which is there as part of our calculators. Now, hypernatremia is rare, but you have to think of DI as a possibility. First, exclude mannitol use, salt load, and diabetes. If urinary osmolality is low, concentrated blood, dilute serum, that is DI. Queda AVP response, positive, this is central, negative, this is nephrogenic DI. If the urinary osmolality is high, concentrated blood, concentrated urine, and the urinary sodium is high, that is sodium load. Urinary sodium is low, that is the extra renal loss or sweating. But mostly, we are talking about chronic hypernatremia is diabetes insipidus in that perspective. So we have this interesting case.
14 days old girl presented with failure to thrive, and the birth weight was 2.6 kg and now presented at 14 days with weight of 2.3 kgs. She was exclusively breastfed and the sodium was 182.
So do you think this weight pattern is good or it's something of concern?
So by this age, the baby should have regained the birth weight, sir. And
so this is a dangerous scenario,
Dangerous
and this is something which is 182. Can you guess the gravida of the mother?
she must be primary gravida, sir. And there's
Most common is the primary gravida. And what we do in terms of workup, what we see is that
we need potassium level
is normal. Urinary osmolality here is high, 1000. And then
that means urine osmolality is high. That means it must be a high sodium load, sir, in this patient.
So this is a sodium load. Most likely scenario is breast milk related hypernatremia, most commonly seen in primary gravida mother. A lethal disorder which should best be prevented.
Yes.
If you ensure that somebody is not gaining weight, give them extra feed or top feed or whatever to prevent this from happening. So this was a scenario in that regards. 3-month-old girl with altered sodium.
The sodium is 170. The potassium is normal. And
So what will you do from here? Will you do a water deprivation here?
so in this case, already patient is hypernatremic, so there is no need of water deprivation test, sir.
So clearly you look at urinary osmolality,
It
which
is
is
low.
less.
It is low.
So
We-
you go for AVP response to
response.
classify. So again, that algorithm is running on parallel. It will diagnose this is most likely a DI, and then
Yeah.
you can use a AVP test to identify central versus nephrogenic. So we have developed a very simple tool which includes all the electrolytes: hyponatremia, hypernatremia, hypokalemia, hyperkalemia, based upon just sodium, potassium, and basic inputs. Now, again, hypernatremia management is also a challenge. So, like for DKA and like for hyponatremia, we have also developed based upon the overall parameters to incorporate all the things to have a gradual loss. How much loss in sodium you want to do in a hypernatremic individual?
In hypernatremic, sir, the correction should be gradual, sir, not more than 9 to 12 in acute cases.
So if it's acute, you can go up to 10 to 12. If it's chronic, 6 will be the upper limit. So you don't want to give too much. General dictum is N by 2, 120 to 130% maintenance. This is what we're looking at. But if you want to have specific guidelines, we have developed a calculator which will tell you how much fluid is to be given per hour to achieve that correction. So this is something which can be used for a precise one. Otherwise, the management is there. Finally, hypokalemia is a common presentation more from pediatric perspective, but not from an endocrine perspective. But if you have hypokalemia with alkalosis, you're dealing with an endocrine excess. So the most important investigation here is the blood gas. Everybody who is hypokalemic should have metabolic alkalosis. If you have metabolic acidosis, then there are only 3 scenarios: RTA, diarrhea, or the use of the drugs which can cause acetazolamide, which can cause diamox, which can cause that scenario. Second thing to look at, of course, is magnesium and blood pressure. So our algorithm is looking at how much is your pH, how much is your magnesium and blood pressure, and classifying based upon that. So just very critical parameters to look at. So exclude diarrhea, diuretic, and malnutrition. Blood gas shows acidosis. Then you differentiate diarrhea from RTA using a urinary anion gap. Urinary anion gap is a marker of urinary acidification. If it's positive, it is RTA. Negative, it is GI loss. If blood gas shows alkalosis, blood pressure is low, you're thinking of Barter, Gitelman, diuretic use. Urinary calcium is high, Barter. Urinary calcium low, Gitelman. If its blood pressure is high, look at aldosterone. Hyperaldosteronism or low is DOC. And then you can classify based upon the response into CAH variants, AME, or littles, which are rarer. So hypertension with hypokalemic alkalosis, think of endocrine causes from that perspective.
2 months old boy presented
Yeah.
with failure to thrive, and the potassium is 2.8.
Yeah. So here, what you're looking at, of course, the first thing is to look at the acidosis status. There is
So,
metabolic acidosis. So now,
since there is metabolic acidosis, now we'll straight away think about the anion gap, sir, and
Yes.
the urine.
so urinary anion gap will give you a clue. So what
So
you're seeing here is that
this is a
urinary anion gap is
positive,
positive.
positive anion gap, urine anion gap. So it is mostly RTA, sir.
So RTA could be a possibility. So again, you put the data and you will get it from the interpreter. And if you remember, this is the most important presentation in that perspective. When urinary pH is more than
6.3,
6, it is
distal RTA.
Yeah, 3
This
months.
is 3 months old girl presented with failure to thrive, and the potassium is 2.2. Birth weight was 2.8, and presently it is 3.5 kgs.
So not much of a gain. So next issue, of course, will be how much is your blood gas,
Blood gas.
which shows metabolic alkalosis. So it is showing 7.54. Bicarbonate is also on the higher side. Base excess is high. So this is metabolic alkalosis. The next step is to look at
Blood
the
pressure.
blood pressure, which is normal, and blood pressure is not there. Look at magnesium. And magnesium here is normal and urinary calcium is high.
So it
this
is
is a
Bartter syndrome.
So again, if you go by the algorithm, you go by the interpreter, you will get the likely diagnosis. Next
2
is
years old boy presented with failure to thrive, and the weight is 8 kg, height 85 centimeter, and the potassium is low, which is 2.4. There is metabolic acidosis with bicarbonate of 38,
alkalosis. Yeah.
alkalosis with bicarbonate of 38, and the blood pressure is normal. Urine calcium creatinine ratio is less than 0.2.
So we are dealing with a scenario where you have normotensive, hypokalemic, metabolic alkalosis with normocalciuria.
Calciuria.
So major step there will be to look at magnesium level,
Magnesium levels.
which will then give you whether it is a malnutrition related. Magnesium is low. So this is a malnutrition related hypomagnesemia.
1 year old boy presented with failure to thrive. The potassium is 2.4.
Yeah.
And pH is 7.52, which is metabolic alkalosis with bicarbonate 32. And the BP is for 1 year, it is high, 120/70. So now BP is high, then sir.
So we have hypertensive, hypokalemic alkalosis. So now the algorithm doesn't go too much because then it becomes too much. So we have just recommended there that you do a PRA, DOC and aldosterone level because this is the area where we need to have specialist inputs. So then renin is low, aldo is undetectable. So what do you think here?
Then renin is low.
It is opposite to your case of pseudo-hypoaldosteronism, where high renin, high aldo, low BP. Here, high BP, low renin, low aldo, which means it's a distal defect. So just the diametrically opposite, we discussed about the epithelial sodium chloride channel. This is the increased activity of epithelial sodium chloride channel. So AME versus a possibility of Liddle. So either of them can cause this sort of scenario. Thank you, Dr. Sandeep, for this discussion. So we are moving towards the final part about calcium disorder, and we have developed a calcium interpreter which is covering both hypocalcemia as well as hypercalcemia. So when we talk about hypocalcemia, the most common cause is vitamin D deficiency. But what we are concerned from an endocrinologist perspective is PTH problem. The most important investigation in a child with hypocalcemia is phosphorus. Everybody with hypocalcemia should have low phosphorus. If you have a high phosphorus, think of a pseudo-hypo, hypoparathyroidism or renal insufficiency. Second is PTH. If your PTH should ideally be above 70 in somebody who has hypocalcemia, a PTH which is less than 70 with hypocalcemia is inappropriate response. Everybody should, of course, vitamin D becomes important, and important would be urinary calcium. If you have less calcium, urine calcium should be 0. If you are having hypercalciuria, that is calcium sensing receptor defect. So approach, as I said, starts with phosphorus. But before that, you want to exclude magnesium, albumin, and phosphorus load. If phosphorus is low, think of vitamin D related causes, look at 25-OHD and then VDDR1 and 2. If it's high, think of renal failure or PHP losing creatinine. And remember that calcium and PTH have a log linear relationship. If your calcium is low, PTH should be high, above 70. This is PHP or secondary. If PTH is inappropriately low or normal, this is hypoparathyroidism. Remember, PTH is a very labile hormone. If you do not transfer it in ice, you will have a problem in terms of assessment and you will have a falsely low level. So start with the cases, Dr. Alapan.
So I'll start with the case of a 4-month-old boy presented with nephrotic syndrome and a calcium of 7.2 milligram per DL, which is low. So now the child is asymptomatic, and let's see what our interpreter gives regarding this.
So what we'd like to know here?
We'd like to know the albumin level in this case because the child is a nephrotic syndrome case, and before
the albumin here was low, of course, and you
So,
found the albumin of 2.2. And how will you correct this?
So every decrease of 1 milligram of albumin, the calcium should decrease by 0.8. There is a formula about this. Corrected calcium equal to measured calcium plus 4 minus albumin into 0.8 milligram per DL.
Normal. If you correct it by around 1.6, it becomes 8.8. So this is not hypocalcemia.
Calcium. So moving on to the next case, a 4-year-old girl child presented with tetany, symptoms of hypocalcemia. Ionic calcium is 3.1 milligram per DL. So in this case, this is a low calcium, so we should look for the phosphate level, as sir has already described. The phosphate level in this case is high. So before labeling somebody as a PTH related disorder, we should always first look for the creatinine level in these scenarios.
What we've done in this algorithm is a bit different. So if you look at it, rather than, so we don't want this mistake to happen at all. So we are not asking for phosphorus at an early stage. What we are saying is that if you are hypocalcemic, first tell us what the creatinine is, so that this mistake will not happen. So what happened in this case was phosphorus was high, PTH was high, labeled as pseudo-hypoparathyroidism. But if you look at it, the first thing which comes is creatinine, so that immediately this is not missed out. Second thing which will come is magnesium. Then it will come to phosphorus, so that you are not confused at all. So this clearly is a case of renal insufficiency, which was misdiagnosed as PHP, which is unfortunate in that regards.
So again, the next case, the 1-year-old boy child presented with seizure with ionic calcium of 3.2, a low calcium level. And now the phosphate level is on the normal range. And the PTH is low and labeled as a case of hypoparathyroidism.
So again, do you agree that this is hypoparathyroidism?
So before labeling someone as hypoparathyroidism, we should look for the other ions like magnesium. We should see in
So
this
that
cases.
is why if we look at the algorithm, what it is asking is that it is asking after creatinine normal, asking magnesium. So if you remember our algorithm, we are saying exclude magnesium, phosphorus load and renal failure. So they are being excluded there only. So that's why we are asking it early.
So there is no response to the IV calcium. The magnesium level was low in this case, which having a TRMP6 defect and requires
TRMP6?
It's a magnesium transporter present in the distal tubule. Sorry.
In the intestine as well as the kidneys, both places. So these are the most refractory cases. And you remember there are two siblings who are taking 10 grams of magnesium sulfate and they're doing fine. So this is a rare scenario, but then interesting one. Carry on.
So moving on to next case, a 3-month-old girl child presented with seizure, ionic calcium of 3.2 milligram per DL. So again, a case of hypocalcemia with symptomatic hypocalcemia, and phosphate level is low in this case, 2.2 milligram per DL, and PTH level was also low in the scenario.
So labeled as hypoparathyroidism. Do you agree?
Sir, we have to always see for also the phosphate level in that in this scenario. In cases of hypoparathyroidism, the phosphate level should be much higher. So more likely a case of vitamin D deficiency in this scenario.
So phosphorus is a biomarker, the bioassay for PTH activity. If your phosphorus is low, it means there's no way your phosphorus will be low unless PTH is there. Let's put it in a very simple term. So it means that PTH, I am not going to believe this PTH report. And if you go by algorithm, what it is saying is that you look at the ionic calcium, you can start the algorithm.
Yes.
So calcium is on the lower side, creatinine of
Is
course is
normal.
normal. It will ask creatinine, it will ask about magnesium then, and magnesium was also normal. So now the issue would be what is the phosphorus? So after creatinine and magnesium, it will ask for phosphorus, which is low. So we have excluded if the phosphorus is low, we don't ask for PTH. You will go for vitamin D. And if we had done this interpreter, we would get the right result right away. And this was a vitamin D deficiency. If you want to send PTH, either send the patient to the lab rather than going to a collection center. He goes to the proper lab or he takes the sample in the ice. The collection person has to do that, which is rare. So this is a major issue in terms of PTH.
So yeah, probably the PTH low is due to the transport defect in that scenario. And again, the next case of 1-week-old boy presented with symptomatic hypocalcemia, seizure, and phosphorus level in this case is high. So we should always see for first the creatinine level, whether high or not. The creatinine is normal in this case and PTH is high.
Yeah.
So
this looks like a pseudo hypoparathyroidism.
No, we should always before labeling someone as pseudo hypoparathyroidism, we should look for the vitamin D status also, because sometimes the vitamin D chronic deficiency can also present like a.
So this is a very important message which is there. So if you have long-standing vitamin D deficiency, there will be induced PTH resistance. So this looks like pseudo hypoparathyroidism, but I will not be very confident. 1 week, very rarely for pseudo hypoparathyroidism to present. So if you look at what is clearly mentioned, this is not 1 week actually, this is 11 years, some mistake there. So anyway, it recommends 25 OHG levels. But if you look at the child, he has other feature, there is cataract,
there is brachycarpia, there is a calcification is present in the below the skin.
So this is a classical case of pseudo. So this is an older child, but even there, before you make a diagnosis, vitamin D becomes important. Carry on. So hypercalcemia is a rare scenario. And again, the most important thing here is phosphorus. Anybody who has hypercalcemia because of hyperparathyroidism should have a low phosphorus. If you have a high phosphorus, this is PTH independent. And the most common is vitamin D toxicity. Remember, vitamin D toxicity will be more likely to cause nephrocalcinosis because they have lesser absorption of calcium. Other rarer causes include granulomatous disease. The classical feature is birth asphyxia with nodules which are there, which are going to produce 1-alpha hydroxylase, or you can have Other things like sarcoidosis rarely. The other thing to look at PTH, everybody who has hypercalcemia should have a PTH less than 20. Hypocalcemia, PTH more than 70. Hypercalcemia, PTH less than 20. Inappropriately, normal PTH in hypercalcemia is also high. So, hyperparathyroidism, your PTH will give you a clue. Other is hypercalciuria, and vitamin D, of course, becomes important. If you have normal vitamin D and high calcitriol, that is 1-alpha hydroxylase issue from that perspective. The approach is PTH should be below 20. Think of vitamin D related causes. High in vitamin D excess, normal you do calcitriol. High in granulomatous diseases like sarcoidosis, tuberculosis, fat necrosis. Normal in hypophosphatasia. About 20, look at fractional excretion of calcium. Above 1%, think of hyperparathyroidism. Less than 1%, think of a calcium sensing receptor defect. So I think the last three cases probably.
So 12-day-old girl child presented with irritability with dehydration. Ionic calcium is 8. So higher calcium level, hypercalcemia is there with symptoms present of irritability.
Yeah.
Now, so the urine calcium and creatinine ratio is low in this child.
Relatively low.
Relatively low.
And you have to look at the PTH, which is going to be very, very high. So a neonate who comes to you with irritability, constipation, hypertension, hypercalcemia, think of a neonatal severe hyperparathyroidism, which is a defect in the
calcium sensing receptor.
So it's a homozygous defect in the calcium sensing receptor defect. So check the calcium creatinine in the mother urine. And this is not very high because of this defect. Otherwise, it should be sky high.
So moving on to the next case, a 2-year-old girl child with abdominal pain. Ultrasound is showing nephrocalcinosis and ionic calcium is high, 7.5 milligram per DL, with a relatively high phosphorus.
So high phosphorus, high calcium. Do you think PTH will become important here?
No, I think the vitamin D levels should be much more important in this scenario, and we have seen a vitamin D level is high in this scenario. So probably the child has taken too much vitamin D from exogenously.
So again, the message is if you have hyperparathyroidism to develop nephrocalcinosis, it is going to take time. But if you have vitamin D excess, and mother in this case was giving sachet daily for 20 days, it will acutely cause this nephrocalcinosis. This is something you need to be aware of.
So moving on to the last case, the 4-day-old boy presented with seizures, birth weight of 3.2 kg with birth asphyxia, history of birth asphyxia present. And he has ionic calcium of 10 milligram per DL with phosphorus in the high normal range, 4.2.
Not low.
Not PTH is low in that scenario.
So we are dealing with a non-PTH or a PTH independent cause with a high phosphorus. Of course, you have to think of other things in that perspective. So this will be a fat necrosis. So thank you, Alapan, for summarizing that. So over the last 2 hours, we have been able to cover 6 key aspects of pediatric endocrinology, including growth, puberty, DSD, thyroid, calcium, electrolyte, and glucose. And we have tried to cover it. This has, of course, been a very fast track presentation. But the aim is like that this is how you want to do it in clinical practice and use the mobile application to fast track. Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MediClasses endocrinology app. It's available both on Android and iOS store. And the latest version should be on track. I think today or tomorrow it will be uploaded. We'll send an email about that. And you can all go and have a look at it. Send us a feedback. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective. I'd like to acknowledge all the people who have been part of this program, Professor Menon and Professor George Bertha, Dr. Neha, Dr. Chetan, Dr. Riddhi, Dr. Sajili, and Dr. Hemang. Hemang was particularly important from the perspective of development of a DKA tool. Then Dr. Pradeep, then our tech team, Dr. Sayan, Dr. Naveen, Dr. Manoj was part of many of the tools, Vibha, particularly for thyroid and many other big aspects. Then Dr. Dhwani, Dr. Alapan, Dr. Sandeep, and the collaborative team which is there from that regards. The app is available online and you can have a look at both Android and iOS store, and you can subscribe from there or from our website. And at the end of it, we will like to thank all of you for this being a long session. We will see if there are any particular questions available. You can really ask those questions, and I'm happy that still a lot of people are joining after 2 hours of extensive one, which is there. Dr. Dhwani, I think, is there, who is watching. So if Dhwani wants to talk, you can allow you to talk also, because we missed you. This is the first session after Dhwani has gone. So I think Dhwani is there. So I think overall the aim of this app is to make life easier and to ensure that we have a quality-based management based upon the scenarios from that perspective. So Dhwani, have you joined back? Okay, so I think Dhwani is somehow not able to join in probably. If there are any questions, we will take up there, or we will then close the session, and we will love to have your feedback about the new app, particularly the key tools which have come up are the electrolyte interpreter, the calcium interpreter, the hypoglycemia interpreter, the thyroid nodule interpreter, which are going to really help out in terms of immediate assessment of a number of conditions from that regard. So I think we will close the session from there, and thank all of you for patient hearing. Thanks all the team, especially Dr. Vibha, Dr. Alapan, Dr. Sandeep, Dr. Nimisha, Nikhil, and Prashant, who are part of the team on the back end. And hope this will